Good afternoon. On behalf of Ceylon College of Physicians, we welcome you the Symposium on Endocrinology. Today we have three eminent speakers to speak on two important areas in endocrinology. First two speakers will be speaking on virtually, and the final speaker will be speaking physically. The questions, you can use the chat box to ask the questions while the presentation is going on. At the end of each presentation, depending on the time, we will allow for the questions. So I would like to invite the first speaker, Professor Arjuna Madagama. He is Professor in Diabetic Medicine, University of Peradeniya, MBBS, MD, FRCP, and FCCP. He will be speaking the place of newer oral agents in diabetes, a critical analysis. Over to you, Arjuna.
Good afternoon, and it is indeed a pleasure to be here this afternoon with the Ceylon College of Physicians annual academic sessions. And for the next 20 to 25 minutes, I will be talking to you on the newer oral medications in diabetes. Why are we interested in diabetes? Because it greatly increases the risk of cardiovascular disease. Patients with type 2 diabetes have twice the risk of cardiovascular disease compared with those without it. And the mortality from type 2 diabetes is primarily of three causes: atherosclerotic cardiovascular disease, heart failure, and kidney disease. Diabetes is also associated with an increased risk of heart failure, and diabetes increases the risk of developing heart failure by 2 to 5-fold. And more interestingly, the presence of heart failure also increases the risk of developing diabetes. The heart failure of diabetes is a result of diabetic cardiomyopathy, which is defined as the presence of either systolic or diastolic dysfunction in the absence of conventional risk factors such as coronary artery disease, hypertensive heart disease, or valvular heart disease. And moreover, both diabetes and heart failure act as individual risk factors for the development of each other. However, when the two are combined, the prognosis is significantly worse, with a median survival of less than 4 years. Patients with diabetes are also at a higher risk of kidney disease. Diabetic kidney disease is estimated to affect nearly 50% of patients with diabetes globally, and remains the most common reason for progression to end-stage kidney disease in many parts of the world. So it is time that we shifted there's a paradigm shift in treating diabetes from a glucocentric approach to one that reduces cardiovascular and renal outcomes. The ideal medication for diabetes should be one that obviously lowers the HbA1c, improves cardiovascular, heart failure, and renal outcomes, and at the same time be able to reduce blood pressure and promote weight loss. Why is cardiovascular safety so important? I'm sure all of you would remember that in 2005, rosiglitazone was found to be associated with an increased risk of cardiovascular outcomes. And this led in 2008 to the FDA issuing guidance mandating assessment of cardiovascular safety of all antihyperglycemic agents in RCTs. And this led to three new classes of drugs, namely the DPP-4 inhibitors, the GLP-1 receptor agonists, and the SGLT2 inhibitors being subjected to extensive cardiovascular outcome trial testing. And this resulted in a plethora of cardiovascular trials, and some have been reported up to date. I'm not going to bore you with the details of all these trials, but pick out the salient facts for the discussion. For the bulk of the remainder of my talk, I would be concentrating on sodium glucose cotransporter 2 inhibitors. As you very rightly know, the SGLT2 inhibitor is located on the proximal convoluted tubule of the nephron and is responsible for reabsorption of 90% of the filtered glucose. and inhibition of this receptor results in a large amount of glycosuria exerting a clinically useful action. And you would know that the action of the SGLT2 inhibitors is insulin independent, and that they cause a useful caloric loss, results in osmotic diuresis, and also results in natriuresis. So are they any good when it comes to treating diabetes? Yes, all three drugs tested extensively, namely empagliflozin, canagliflozin, and dapagliflozin, reduced the HbA1c by about 0.7%. They also result in useful weight loss from 2 to 3 kilograms, and also cause a reduction in systolic and diastolic blood pressures of about 4 and 2 millimeters respectively. However, there was some more evidence from the cardiovascular outcome trials which showed that they were also able to reduce major adverse cardiovascular events by about 14% with empagliflozin and canagliflozin. However, the most striking outcome of these trials was a reduction in the hospitalization for heart failure, which amounted to about 35% across the board for all three medications. While the reduction of major adverse cardiovascular events was observed only in patients with pre-existing disease, the reduction of heart failure was independent of pre-existing cardiovascular disease or pre-existing heart failure. So are these beneficial effects achieved solely through the lowering of HbA1c? Most probably not. As you would see from the results of the empagliflozin trials, that the beneficial effects actually separate out very early in the trial, within actually 1 month of initiating SGLT2 inhibitors. And this is thought to be a result of the reduced content of intra-body sodium, reduction in interstitial volume, and an improvement in diastolic function. The unexpected favorable outcomes in improving heart failure resulted in renewed attempts to find out if SGLT2 inhibitors were effective in treating heart failure in patients with and without diabetes, as well as to see if they were effective in heart failure of reduced and preserved ejection fraction. The first hint that they were effective in patients with heart failure with preserved ejection fraction came from a subgroup analysis of the DECLARE-TIMI 58 trial. And then on, there were several trials which were dedicated, heart failure trials, which went on to find out if these agents were effective. The DAPA-HF trial, they reported their results in late 2019, and the Emperor Reduced and the Emperor Preserved trials reported their results very recently. And what did we find from these trials? We found that the SGLT2 inhibitors were effective in heart failure with both reduced and preserved ejection fractions, and they were also effective in patients with and without diabetes mellitus. Moreover, empagliflozin seemed to be more effective in patients with advanced heart failure compared to dapagliflozin. What are the possible mechanisms of improving heart failure? As I told earlier, the hemodynamic effects of osmotic diuresis, natriuresis, and volume contraction probably plays a major role. The second most important mechanism is probably the substrate, a change in cardiac substrate utilization by the failing heart. The failing heart uses the glucose as a very poor energy source, but with SGLT2 treatment, there is an increase in the beta hydroxybutyrate oxidation. And this leads to improved myocardial contractility, leading to reduced incidence or progression of heart failure. Another very important concept is that the SGLT2 inhibitors favor greater interstitial fluid loss compared to other diuretic agents. And if you would see here, if I compare SGLT2 inhibitors with a loop diuretic, you would see that the loop diuretic causes a large contraction of the blood volume, whereas the SGLT2 inhibitors would minimally contract the blood volume. If I were to show that to you in a more diagrammatic form, this is a blood vessel in heart failure with interstitial edema, and in SGLT2 inhibitor treatment, there is preserved vascular filling with loss of interstitial edema. However, if a loop diuretic was used, you can see that the interstitial edema is still gone, but however, there is contracted volume in the blood vessels. And more importantly, this reduction in the volume is not associated with an increase in sympathetic activity, as it is the case with most loop diuretics, because it causes an increase in troublesome tachycardia. This was not observed in trials and other experiments using SGLT2 inhibitors. Another useful mechanism that is probably responsible is the inhibition of the sodium hydrant hydrogen exchange on the myocardium. On the failing myocardium, there is accumulation of cytosolic sodium and cytosolic calcium, which leads to aggravation of heart failure. However, with SGLT inhibitors, the cytosolic sodium and the calcium is reduced, leading to better myocardial contractility. So this is what I have just talked to you about in a diagrammatic form. So if we just summarize all the clinical trials we have on the commonly known or the more commonly used medications, empagliflozin, canagliflozin, and dapagliflozin, there is good evidence to show that they unequivocally reduce the hospitalization for heart failure across all three drugs. There is a reduction in major adverse cardiovascular events as well with empagliflozin and canagliflozin, but this was not demonstrated with dapagliflozin. The same, unfortunately, cannot be said for most of the other newer medications available for diabetes. The GLP-1 receptor agonists, they do have some useful effects in reducing major adverse cardiovascular events, but they do not have much effect in reducing the hospitalization for heart failure. Diabetes is also a leading cause of end-stage kidney disease. Approximately 40 to 50% of patients with diabetes develop DKD along the line. For 2 decades, no new treatments were identified for the treatment of diabetic kidney disease. Since Renal and IDNT, which reported their results over 2 decades ago, several agents have been tried for their efficacy in reducing the progression to end-stage kidney disease, but all therapies have not shown any promise. If I may just take a moment to remind you of the pathophysiology of diabetic kidney disease, it is primarily the result of the development of intraglomerular hypertension. And this is either a result of afferent arteriolar dilatation, efferent arteriolar contraction, or both, which leads to increased intraglomerular hypertension, which leads to hyperfiltration, resulting in albuminuria and progression to end-stage kidney disease. Among other mechanisms, the inhibition of the tubulo-glomerular feedback, which involves the macula densa, is thought to be the primary mechanism by which diabetic kidney disease progresses. And with the loss of this feedback mechanism in diabetic kidneys, there is dilatation of the afferent arteriole, which leads to increased intraglomerular hypertension and results in albuminuria. With SGLT2 inhibition, there is what is known as the re-establishment of the macula densa mechanism, leading to the so-called inhibition, the juxtaglomerular feedback mechanism, which then causes afferent arteriolar vasoconstriction. And this afferent arteriolar vasoconstriction will reduce the intraglomerular hypertension and then reduce the albuminuria. So this is a multiphoton microscope imaging, which again shows you the afferent arteriole before and after initiation of SGLT2 inhibitors. Here you can see that the arteriole is dilated, but after the initiation of SGLT2 inhibitors, the arteriole seems contracted. Most of the results we have, or the data we have on diabetic kidney disease, are from trials which were primarily done as cardiovascular outcome trials involving empagliflozin, canagliflozin, and dapagliflozin. However, now we have several ongoing clinical trials which are looking at, as dedicated clinical trials, which are looking at the renal outcomes over a period of time. DAPA-CKD is a trial which have reported their results recently. The other trials are still ongoing. If we look at the data we have from the cardiovascular outcome trials, where they measured also the kidney outcomes, you can see very clearly that there is a reduction in the kidney outcomes. There is a reduction in the progression of renal disease, doubling of serum creatinine time, and the initiation of renal replacement therapy. While another trial, the Credence, showed very much the same results during its period. The DAPA-CKD trial, which concluded very recently, showed that it was also able to reduce the risk of kidney failure, that it reduced the risk of cardiovascular death or heart failure for hospitalization, and that it also prolonged survival. Here again, just like in the cardiovascular outcome trials, the available evidence from the CVOTs and from the existing evidence shows that unequivocally that the SGLT2 inhibitors play a major role in retarding diabetic kidney disease. So much so that the evidence that we have led to the major diabetes societies to recommend that following the initiation of metformin for diabetes, the clinician should establish whether there is atherosclerotic cardiovascular disease, heart failure, or CKD. If either heart failure or CKD is a prominent feature of your patient, the second choice of drug would now be an SGLT2 inhibitors. However, if atherosclerotic cardiovascular disease predominates, you still have the choice of either starting a GLP-1 receptor agonist or an SGLT2 inhibitor with proven CV benefit. How about the safety profile of these inhibitors? They are well established and hardly cause any trouble. There can be a slight increase in genital infections, and if combined with other agents, there might be a slight increase in the incidence of hypoglycemia. Euglycemic diabetic ketoacidosis is a rare complication of SGLT2 inhibitors, and canagliflozin has been associated with a slight increase in lower limb amputations. However, rare cases of Fournier's gangrene have been reported with some of the SGLT2 inhibitors. A word of caution when you are using SGLT2 inhibitors, it depends on the country that you're practicing, but generally, if there is an eGFR of less than 60, they are not initiated as primary agents. If we still consider the three new classes of medications we had in mind, the DPP4 inhibitors, GLP-1 receptor agonists, and the SGLT2 inhibitors, how do the other classes of medications fare with regard to cardiovascular outcomes? DPP4 inhibitors unfortunately did not show any superiority over the placebo when it comes to cardiovascular outcomes. Saxagliptin, on the other hand, a DPP4 inhibitor, was associated with an increase in the risk of hospitalization for heart failure. The future of oral hypoglycemic agents, the GLP-1 receptor agonists had many cardiac beneficial effects, but were at a disadvantage as they had to be injected. However, new breakthrough technology now enables GLP-1 receptor agonists to be given orally. So I'm just showing you a diagrammatic picture how the newer molecule, oral semaglutide, crosses the gastric mucosa through combining itself with a molecule known as salcaprozoate sodium, and is available to exert its mechanism. And this trial, which was known as the Pioneer 6 trial, showed that semaglutide, the oral semaglutide, was able to be was an effective glucose lowering agent, but however, it was not any better than the placebo when it comes to cardiovascular outcomes. So they concluded that oral semaglutide demonstrated non-inferiority for the primary outcome of major adverse cardiovascular events. So is there any drug which actually ticks all the boxes? How do we compare the SGLT2 inhibitors, the GLP-1 receptor agonists, and the other classes of medication in terms of renal and cardiovascular outcomes? Unfortunately, there is still only one class of medications, or fortunately, we still have the SGLT inhibitors, which actually addresses all categories of adverse cardiovascular events, cardiovascular death, heart failure, and the renal outcomes. So in summary, SGLT2 inhibitors, primarily developed as oral hypoglycemic agents, have recently emerged as potential therapeutic options for other diseases such as heart failure, EKD, and CKD. The SGLT2 inhibitors show superiority in reducing major adverse cardiovascular events and cardiovascular deaths and hospitalization for heart failure among the newer oral hypoglycemic agents. They improve the heart failure in both patients with reduced and preserved ejection fractions. They are also effective in patients with heart failure who have diabetes and who do not have diabetes. On the other hand, the other newer classes of drugs such as DPP-4 inhibitors have no beneficial cardiovascular effects. SGLT2 inhibitors are better in improving renal outcomes compared to other oral agents. Oral GLP-1 receptor agonist semaglutide, while effective as an oral hypoglycemic agent, does not have beneficial cardiovascular effect. So I hope that I have been able to shed some light and critically analyze some of the data that we have on a newer class of oral medications, the SGLT2 inhibitors. Thank you very much for listening. Thank you.
Thank you, Professor Arjuna, for that very informative and analytical lecture. Now we move to the next speaker. She is Dr. Chandima Idampitiya, consultant endocrinologist at North Cumbria Integrated Care NHS Foundation Trust, United Kingdom. And she will join us virtually today with a pre-recorded talk. Please feel free to send any questions if you have.
Thank you very much for the kind introduction. I would like to take this opportunity to thank the President of the Ceylon College of Physicians, Dr. Ananda Vijayvikrama, for inviting me to contribute to the session on endocrinology. Over the next 20 minutes, I will try to provide you with a brief overview on challenges of insulin therapy. The aims and the objectives of this session are to identify and discuss the challenges associated with insulin therapy, especially in people with type 1 diabetes, and to discuss the ways and means of overcoming those challenges. And in the last few minutes, I will highlight the technological advances in recent years which are related to glucose monitoring systems and insulin delivery systems. So in the year 2021, that's next year, we will be celebrating the 100th anniversary of insulin discovery. When we go back to the history, in 1921, Fred Banting and Charles Best from the University of Toronto purified insulin from the dog's pancreas. Since then, the insulin has come a long way. In 1923, the first commercial insulin was produced by purifying animal insulin. And in 1966, the first synthetic insulin was made. In 1982, human biosynthetic recombinant insulin, Humulin I, was produced. And in 1999, the first analog insulin, Humalog, was approved. Since 2003, the Lantus, a long-acting analog, was available. And from 2005, a Levemir, another long-acting insulin analog, was available for us to use. And in 2013, the first ultra-long-acting insulin Tresiba or Degludec, was approved by the European Medicines Agency. So there has been a significant development of insulin over the years. However, the patients who are on insulin face a lot of challenges. Those can be categorized as physical, psychological, or social challenges in one way, patient-related, healthcare system-related, or clinician-related challenges in another way. However, these challenges overlap each other. So what are the physical challenges? After all, insulin is an injection. So the insulin delivery method is a big challenge. There had been several attempts to change the delivery method by using nasal insulin or inhaled insulin over the years, which hasn't been very successful. Another problem is the complexity of the insulin regime. If someone is diagnosed with type 1 diabetes, they will have to take multiple daily injections, a basal insulin and prandial insulin with each meal. So this usually is about 4 to 5 injections a day. It's not just only that, they have to monitor their blood glucose regularly, which is painful and it takes time. The side effect of insulin, particularly hypoglycemia, is a challenge. There are other side effects, such as lipohypertrophy and lipodystrophy. This mainly happens when a patient is on long-term insulin and injecting insulin into the same area. You can see in the photographs. Hypersensitivity to insulin is a problem. And another problem is the weight gain. Insulin status manifested in patients with diabetes. It could be either anger, stress, or denial. Another main psychological challenge is the fear of hypoglycemia. It is real, especially when people live on their own. It's a major problem. Another challenge is anxiety and depression. Especially the people with diabetes have about 30% of increased risk of developing anxiety and depression in their lifetime. In addition, eating disorders are common in people with diabetes. It could be either bulimia or anorexia. but also disordered eating behaviors are very common. Most of the time, people try to control their eating, to control the blood glucose or control the weight. What are the social challenges? Management of diabetes depends on the socioeconomic status of the patient. Patients with diabetes who are on insulin face significant problems in education, unemployment, and the job security. There is a variation of accessibility to healthcare resources in the world, and even in the United Kingdom. We call it postcode lottery. In addition, people with diabetes, especially the young people with diabetes, it's an enormous challenge for them to change their lifestyle. Can lead to breakup of their relationships, and it is associated with the social stigma when they have to inject insulin in the public spaces. Over the last few years, the public perception of having to inject insulin has changed a lot, but patients still face the problems. So over the next few minutes, I'm going to talk about hypoglycemia, as it is one of the major challenges faced by patients. It is either physical, psychological, or social. Hypoglycemia is defined as a blood glucose of less than 3.5 millimoles. And it is well known that the recurrent hypoglycemia is associated with impaired hypoglycemic awareness, or sometimes completely losing the hypoglycemic awareness. The DCCT trial had shown strict glycemic control is associated with increased risk of hypoglycemia. There had been 3 trials on people with type 2 diabetes, the CODE, ADVANCE, and VADT trials. Those trials had shown there is an increased risk of mortality with recurrent severe hypoglycemia. So I'm going to talk about a patient who has been referred to me a few years ago. He's a 72-year-old gentleman who had type 1 diabetes for 40 years. He was retired, but he had an active life. He was a keen sailor. When he was referred, his diabetes control was good. His HbA1c was 53 millimoles per mole. He had background retinopathy and hypercholesterolemia. He was on a basal bolus insulin regime, which comprised of Lantus and no rapid insulin. He was referred to us due to severe episode of hypoglycemia, which required third-party assistance. Before that, he has been managed in the primary care. So when he was referred, he was on a basal bolus regime. The basal bolus insulin regime comprised of a bedtime long-acting insulin, which lasts for 24 hours, and another rapid-acting insulin, which eat meals, which are usually a soluble or a rapid-acting analog. So for this patient, we offered him structured education. The structured education we use in our trust is DAPHNE, which is called dose adjustment for normal eating. And then we have advised him regarding reducing the risk of hypoglycemia in order to regain his awareness. He was reviewed a few weeks later. He didn't have very severe episodes. However, he continued to have hypoglycemia. continued to have impaired awareness of hypoglycemia as well. He had to surrender his driving license, and he hasn't been able to do his normal activities. He ended up in deteriorating his glycemic control. So we arranged him to have continuous glucose monitoring, which showed the condition dawn phenomenon, and there was a glucose variability in addition. Therefore, at this point, we considered insulin pump therapy to reduce the hypoglycemia. So what is insulin pump? Insulin pump, or continuous subcutaneous insulin infusion, is indicated in patients with disabling hypoglycemia. It's a battery-operated, portable, and a programmable device which continuously delivers rapid-acting insulin via an infusion set. It has a basal rate, which can be varied hourly if necessary, and can be temporarily adjusted as well. Usually the bolus doses are given with mealtime through the pump, depending on an incorporated bolus calculator. So here are examples of pumps. One on your left is a patch pump, and one on your right is a tethered pump. So you can see the difference that the patch pump does not have a wire attached to it. So this patient, he decided that he wanted a tethered pump. So we started him on insulin pump therapy, and we reviewed him after a few weeks. He had less hypoglycemia since starting the pump, but he continued to have impaired awareness. This was even after 4-5 months of starting insulin pump therapy. His awareness didn't improve much. It's not just only that, his lifestyle was affected significantly. He could not get the driving license again. Therefore, at this point, we decided to offer him continuous glucose monitoring. So what is continuous glucose monitoring? We have subcutaneous glucose monitoring systems now. There are 2 types. One is flash glucose monitoring, most commonly known as Freestyle Libre. And then the other one is the continuous glucose monitoring. We have a couple of devices, Dexcom and Guardian Link. So the differences are in flash that it is not real-time glucose monitoring, and it's flash, as the name implies, that you will have to scan the sensor to know what your blood glucose is. In addition, there are no alarms in the current one to know whether the blood glucose is dropping. In continuous glucose monitoring, it is real-time glucose monitoring. In addition, it has alarm systems to warn you if your blood glucose is going down, then you will be able to do something to improve your blood glucose. So for this patient, we decided to use a more advanced technology. It's integrated sense-augmented pump therapy called SAP. In this technique, it combines CSII, which is pump therapy, with continuous glucose monitoring using a hybrid closed-loop system. It measures glucose every few minutes and allows real-time adjustment of the insulin. It has low or high alert, and if the blood glucose goes down, the pump automatically suspends insulin delivery. And when the blood glucose starts going up again, it restarts the delivery of the insulin. Not only that, it can automatically adjust the basal insulin every 5 minutes, depending on the glucose readings. So this helped to stabilize glucose levels with very high or low readings. And it is very useful in glucose variability as well. So this gentleman, we started him on sense-augmented insulin pump therapy, and he had no further hypoglycemia. He was able to get his driving license renewed, and he restarted his sailing. And in addition, his HbA1c came down to 47 millimoles per mole. That was an improvement from initial readings. I wanted to highlight this case, especially to show that age is not a confounding factor when you decide the technological advances. So I saw him recently, and this is a record of his glucose readings over the last 14 days. It's a summary that you can see. He has a perfect overnight control. And these little peaks which happens are after food. So we normally expect the blood glucose to rise after food. But the most important thing is there are no hypos. If you look at the time in range on the left-hand corner, you can see that it's only 1% of the time that he had hypoglycemia. And then in addition, about 50% of the time, he's able to maintain his blood glucose within the target range. The next slide is the daily graphs. The purple shaded areas are basal insulin delivery. And you can see when the blood glucose rises, the basal insulin delivery increases. And when the blood glucose comes down, the pump automatically stops delivering basal insulin until the blood glucose starts stabilizing. And to summarize, we all know insulin saves lives. There has been a remarkable progress of insulin types, delivery systems, and monitoring methods over the last 100 years. However, patients on insulin, they still continue to face challenges. And hybrid closed loop system combining continuous glucose monitoring and insulin pump therapy is already approved for patients who meet the criteria, which is really good. I'd like to thank you all for listening. Thank you very much.
Thank you very much, Dr. Chandima, and we very much grateful for your very elaborative and timely lecture given on insulin pumps as well. We are just thinking of getting some of those for our patients as well in Sri Lanka. And there's one question from the viewers. Is there still Somogi effect we consider, or now is it out of practice? What do you think?
I think given the amount of evidence that we see from continuous glucose monitoring and the flash systems, actually there's not a huge amount of, you can't actually say that there's a Somog effect, but what we see is the dawn phenomenon, and the blood glucose start rising, especially around 4 o'clock in the morning. You can see on the continuous glucose monitoring systems that the blood glucose start going up. So not significantly the Somog effect, but I think the hypoglycemia was mainly related to the patients taking insulin, especially at night, or having to have quick acting insulin in the night. So not really, not with the current evidence.
Thank you for that. There's another question, I think. Is there another question? Or, yeah, there's a question asking, why did this patient develop protracted hypoglycemia? Was it due to any other endocrine issue?
No, we usually, when people develop hypoglycemia, we actually check whether they have got other problems associated with whether they have got Addison's or sometimes hypothyroidism or celiac disease. He didn't, but it is well known that when people have type 1 diabetes for a long time, and if they have a significant, really a good control as this patient had, that they most likely to end up in having hypoglycemic unawareness or losing the awareness.
Right. There's another question coming from Dr. Priyankara.
How is your experience using insulin pump in pregnant mothers?
I think the experience is because the patients who are on insulin pump, we continue the insulin pump therapy during pregnancy. And during the first trimester, it is really useful. The problem is that because they are actually the first trimester, the patients have a lot of significant hypoglycemia. Because of that, it's very useful. But when it comes to the third trimester or the second trimester, there's not a huge amount of data, or even the other centers. We don't have a huge amount of data to show that the insulin pumps are superior to the Basal bolus regimes. But the current data is that we are able to use continuous glucose monitoring for every single type 1 pregnant patients with type 1 diabetes now. So I think it's a huge advantage for us, because that's actually the game changer.
Thank you very much, Chandima, for excellent presentation.
Thank you very much. Thank you.
We move to the final speaker. She's Dr. Kalinga Gunawardana. She's here physically, and she's the consultant endocrinologist at District General Hospital, Negombo. She's MBBS, MD, MRCP, and specialist certificate in diabetic and endocrinology UK. She will be speaking on pearls in the management of thyroid disease. Over to you, Kalinga.
Thank you. Over the next 20 minutes, I'll be talking to you about a few topics, hot topics in thyroid disease. So I'll just mention what I'm going to talk to you, not in detail really. These are basically pearls or important factors one would like to bear in mind. We'll be talking about a little bit on hypothyroidism, hyperthyroidism, and special situations in thyroid disease, like in the elderly, pregnancy, as well as subclinical thyroid disease. Let's start with hypothyroidism. Diagnosing hypothyroidism, I mean, it's known from our medical school days, the typical symptoms of tiredness, weakness. I'm not going to take you through all that. But as I'm talking about the pearls, I'm just going to tell you a few things that you might want to keep in mind that might be present in patients without the typical symptoms of lethargy, sleepiness, tiredness, the typical symptoms, where you'd like to screen for hypothyroidism. The first one is the family history. If one has a strong family history of hypothyroidism, we would like to screen our patients for hypothyroidism, especially if there are even minimum symptoms. The second thing is newborns of mothers with thyroid disease. This is again due to the fact that this is autoimmune in etiology now. So therefore, if there is a newborn with a mother with thyroid disease, we'd like to screen them. So this is thinking a little bit out of the box. What about a history of neck irradiation, radioactive iodine, or patients with a history of any thyroid surgery, especially in children? In this day and age where lymphomas or childhood hematological malignancies are cured and they grow into adulthood, they would have been exposed to some amount of neck irradiation. And as adults, they might develop thyroid dysfunction. And in a history, it's very important to screen them. Again, patients on lithium and amiodarone, you have to screen them for thyroid profiles at least once a year. Patients with subfertility and menstrual irregularities. This is another group of patients who might not actually come to you and tell you the typical hypothyroid features, have a high index of clinical suspicion. If they have subfertility, if there's any menstrual problems, do a TSH. Patients with Down syndrome, please do not miss a hypothyroidism in Down syndrome. Patients with other autoimmune diseases like rheumatoid arthritis, vitiligo, type 1 diabetes, do a screening TSH, very simple. I'm just basically giving you a few pearls where the typical features might not be present, and especially in the elderly, where the hypothyroid features might be completely absent. And you might even have just one symptom of just constipation where you'd like to screen them. Apart from these clinical bits, family history and the past history, some investigations might lead you towards hypothyroidism. First thing is dyslipidemia or hypercholesterolemia, especially hypertriglyceridemia, where you keep getting a patient with persistently high triglycerides, might as well do a TSH. Hyponatremia, especially the elderly. Anemia, normochromic normocytic anemia, elevated CPK levels. You have a patient, you put on statins, there's a high triglycerides, patient is complaining of body aches, you're doing a CPK, it's high, possibly it's hypothyroidism. Hyperprolactinemia, another investigation that can go up in hypothyroidism, especially if there's a menstrual irregularity as well. So these are some investigations that might actually lead you towards a possible hypothyroidism without any other clinical features. So these are a few pearls where you actually want to think about hypo. So I'm not going to talk in detail. I'm just going to talk about another bit in hypothyroidism, that is the treatment. So when you actually start, it's not rocket science to start thyroxine for a patient with hypothyroidism, but it's very important to tell your patient right at the beginning that because it's a hormone, it has to be taken on an empty stomach upon waking. Avoid tea, coffee, or any meals for at least half an hour to 1 hour after you take your thyroxine, and try to space it out, especially with calcium and iron, especially in the pregnant ladies, if you're taking those. So this is important to tell them right at the beginning because that's the time they will remember. And also, it's important to tell them where to store it. Because it is a hormone, it is quite liable to high temperatures, and we do live in a temperate country. So if you actually carry it in your handbag or keep it in your car, the temperatures might actually bring down your bioavailability or reduce the amount of thyroxine you carry in your tablet. So keep it in a cool drawer or not in the kitchen where it's pretty hot. That's also important advice. Okay, the last bit about hypothyroidism. This I'm sure everybody comes across. You're giving your patient the adequate replacement dose. They keep coming with high TSH. You just cannot normalize the TSH. What's going on? The most important, the commonest cause is non-compliance. The patient will vouch, I take my thyroxine religiously. If you ask me every day, yes, every day I take it. But if you ask them how many times a week do you forget, they might say, well, a couple of times. So compliance is the commonest cause for non-normalization of TSH. Do establish it. If it is a young adult or an adolescent, maybe you can ask the parents to guide them or supervise their thyroxine uptake, because usually with the hypothyroidism you have a little bit of your memory is not that good and you tend to forget and you're very sleepy and tired, so they might forget. So ask somebody to see if they take their thyroxine. Any other factors affecting the absorption, like taking the thyroxine close to a meal? Any other malabsorption causes like celiac disease, inflammatory bowel diseases? And also look for drugs. There are 3 main types of drugs that will actually affect the absorption, the metabolism, and the binding of thyroxine. The first thing is accelerating the metabolism of thyroxine. Phenytoin, carbamazepine, and rifampicin. These drugs can be used in some patients with diabetes and neurological issues. Certain drugs like HRT for postmenopausal ladies can increase your thyroid binding globulins and then reduce your amount of thyroxine that is in the circulation. Certain drugs can interfere with the absorption. Those are the common drugs like the iron, the antacids, calcium supplements, even cholesterolamine. They will reduce your thyroxine absorption. So ask in the history if these are there. And also, there's interestingly, different forms of thyroxine, levothyroxine preparations have different bioavailabilities. So if the patient keeps changing from one formulation, one brand to another all the time, the thyroxine, the TSH levels might not stabilize. So ask them to stick to one brand or one product or one type of thyroxine. That might help stabilize your TSH. So if you're finding it difficult to stabilize it, perhaps you should go through this list to do that. Right, so those are a few pearls or few clinical challenges you might encounter. What about hyperthyroidism? Again, the presentation, as you all know, the common toxic features, I'm not going to talk to you about it. However, the presentation can be atypical here as well, especially with cardiac type of presentations. Patients can come with unexplained arrhythmias, tachyarrhythmias, especially. I get a lot of my cardiology colleagues referring me, patients they get with atrial fibrillations, tachyarrhythmias, patients who are on amiodarone who develop this. And again, patients with low levels of HDL, patients with nomochromic nomocytic anemias, patients who get osteoporosis or fractures without any major risk of getting a fracture. Think hyperthyroidism. These patients might not have any other feature apart from the fracture. Right. Apart from these abnormal, like odd, rare clinical features, another important pearl to remember is the etiology. Unlike in hypothyroidism, where any etiology, the treatment is thyroxine, in hyperthyroidism, the treatment can vary depending on the etiology. So therefore, isolating what caused the hyperthyroidism is rather important in hyperthyroidism. So Graves, toxic adenoma, these are the main etiologies. It's either Graves, a toxic adenoma, or a toxic multinodular goiter, and rarely can be thyroiditis. So trying to determine the etiology is important. I'll tell you why in a little while. And when we try to do that, we can do it either clinically, using radiological investigations like an ultrasound scan or radioiodine uptake scan, or using a TSH receptor antibody. So in this table, you can see the causes, Graves, the toxic nodular goiters. And if you just have a look at the uptake scans, this is in Graves, where the uptake is very high. So you have a tender diffuse goiter with a bruit, increased vascularity on ultrasound scan. And you might have features like Graves orbitopathy, pretibial myxedema. There's a diffuse uptake, and the TSH receptor antibodies will be positive. So that's Graves. Let's have a look at the nodular goiters, the toxic multinodular goiter or the toxic adenomas. Those two will have, those two will have nodular appearance on clinical and ultrasound basis, and they will have these hot nodules on radioiodine uptake. If it is thyroiditis, the uptake will not show any uptake to the thyroid. So why is it important to know the etiology? I mean, isn't it just carbimazole? Well, it is carbimazole initially. For the first 12 to 18 months, yes, you do start antithyroid for Graves as well as toxic nodular goiters. However, we gradually start tailing off in Graves as well as in toxic nodular goiters. However, in Graves, you can actually stop the treatment and the patients will go into a remission. And you can observe for them to go into a relapse, or they can remain in that remission. But if there is active toxic nodular goiter, it is very unlikely that they will go into a remission. So right at the beginning, you can have a chat with your patient saying, you have a toxic nodule. We might not be able to stop this drug. So we have to think of a definitive mode of therapy, the radioactive iodine or the surgical mode, right from the beginning while we control it. So that's why looking for the etiology is pretty important from the start. So that's a little bit on hyperthyroidism. Let's talk about very quickly about elderly and hypothyroidism. As I mentioned to you before, the symptoms can be very subtle, mostly neuropsychiatric. They can come with confusion, dementia, ataxia, depression. Think hypo. They can be on certain drugs like lithium, amiodarone, I mentioned. Hypothyroidism, hyponatremia. If they have persistent hyponatremia, think. And again, when you start thyroxine in these elderly patients, start at a little bit of a lower dose, perhaps at 25 to 50 micrograms, and then gradually increase your dose over 6 to 8 weeks. What about hyperthyroidism in the elderly? It can be very severe and life-threatening if you miss it, and you can miss it if you don't have a high index of suspicion, because the symptoms again can be absent or subtle. They can even have a monosymptomatic hypothyroidism where you have only one symptom. It's just a thyroid myopathy. It's just a muscle weakness. Or even if they have a AF, it can be an AF with a very slow ventricular rate, or it could be just angina. So it can be a cardiac manifestation. Even that can be atypical. And apathetic thyrotoxicosis, where the patient looks depressed, lethargic, with a lot of weakness, weight loss, cardiac arrhythmias. They might not even have a goiter. So a lot of neuropsychiatric problems, but the diagnosis is thyrotoxicosis. So think a little bit out of the box. What about pregnancy and thyroid disease? A few pearls to keep in mind. The first bit, it's the HCG effect. So this is where a lot of people get confused when they look at a TSH report. So let me just take you through these hormones. I love hormones. So this is the TSH, FSH, LH, and HCG. They have a certain subunit, the alpha subunit in common, and the beta subunit is the one that actually makes them different. So during pregnancy, your placental HCG level goes up. It's very high. So that makes you have a lot of alpha subunits in your body. And due to that, your TSH level comes down during the first trimester, but it goes up gradually during the second and third trimester. However, it remains lower than normal because of this flood of alpha subunits coming from the HCG from the placenta. So it's very normal to have low TSH levels during pregnancy because of this HCG effect. So this is a normal TSH. Usually it's about 0.5 to 5, but in the first trimester, if you can look at these values, it's about 0.1 to 2.5. It's very lab dependent, but if you would see a low TSH and think, oh, this is hyperthyroidism, I must start on carbimazole, that's a disaster, I'm afraid. What about hypothyroidism in pregnancy? It is really important to treat it. Lots and lots of trials over the last decade have come out to show that untreated hypothyroidism during pregnancy can give rise to a lot of maternal and fetal complications, and also impaired fetal cognitive development. Even after 2 years, compared to their peers, children born to mothers with hypothyroidism left untreated will have low IQ levels. And also, ladies who are pregnant or plan to get pregnant should be screened if they have a strong family history of hypothyroidism. So please do not miss hypothyroidism in pregnancy. And a few important bits when you're treating them: overt or subclinical hypothyroidism should be treated. Please tell your young females who are on thyroxine to increase their thyroxine dose by 30% as soon as they know they're pregnant. You don't have to come and see me. Increase it by your own. If you're on 75, make it 100, then you come and see me if you find out you're pregnant. And also keep monitoring your TSH level every 4 weeks, not at the beginning and at the end of the pregnancy, because the levels will vary during the pregnancy. And also don't forget to screen the neonate. One word about postpartum thyroiditis. This is important because we miss it quite a lot, where patients after, during pregnancy, they're fine. After delivery, after about 2 months, they get a bit of sweating, they're anxious, and they put it down to, oh, that's normal. You just had a baby, you're anxious and tired. That is the hyperthyroidism of postpartum thyroiditis. Then after about 6 months, they become hypothyroid. Now they're tired, depressed. That is the hypothyroidism, and then they eventually become euthyroid. However, if you miss it, these ladies go through such a terrible time. Going through childbirth is hard enough. Looking after a neonate is hard enough, but going through all that with a thyroiditis is horrible. So if you think your patient has these features, do a TSH. What about hyperthyroidism in pregnancy? I'm not going to talk in detail. All you have to remember is it's an uncommon disease, but do not treat a low TSH thinking it is hyperthyroidism in pregnancy, because it is a transient HCG mediated TSH suppression, which is a perfectly normal thing in pregnancy. A word or two on subclinical disease. You might see a lot of subclinical disease because we see a lot of thyroid tests being done in every person now. What is subclinical disease? So basically that is when you have normal free T4 levels, but either your TSH is high or low. If your TSH level is high, then you have subclinical hypothyroidism. This is common in females, more in the elderly, and more common in iodine sufficient areas like in Sri Lanka. So the problem is, do we treat it or do we not treat it? Whom to treat? Look at the TSH. If your TSH is more than 10, if you look at the left side of the flow chart, if your TSH is more than 10, treat it. Even if your free T4 is normal, you can treat it. If your TSH is between 5 and 10, repeat it. If it is more than 10, treat it. If it is again between 5 and 10, these are the groups you can consider treating. If the patient has a goiter, if the patient is young with symptoms, tired, can't study, poor memory, yes, do a TPO antibodies. This is one indication where you do an antibody level. If it is high, you know it's going to progress, it's going to get worse. If the patient is pregnant, subfertile, planning pregnancy, do it. If your patient is awaiting a major surgery, like a CABG or a major neurosurgery or something like that with anesthesia, replace. So these are the instances, even with a marginally elevated TSH, you replace thyroxine. What about subclinical hyperthyroidism, where you have a low TSH and a normal free T4? The first thing to do is exclude T3 toxicosis. This can be T3 toxicosis, where you have a normal free T3, but free T4, but your T3 level can be high. If you do it, if it is high, then you have T3 toxicosis. But if you have both your free T3 and free T4 levels normal, but your TSH is low, then you know it's subclinical hyperthyroidism. Then you have to look for possible concurrent use of corticosteroids, non-thyroidal illnesses, which will give a similar picture. Repeat it in about 3 to 6 months. If it is persistent, and if your TSH level is really low, again, we are looking at the TSH. Just like we did in hypothyroidism, where the TSH was more than 10, we treated. Here, we look at the TSH. If it is less than 0.1, in the second column, if it is less than 0.1, in a patient who's more than 65, you treat it. You don't want your patient to go into AF. If the patient is young, then you consider treating if the patient has heart disease, if the patient has symptoms, or if the patient has osteoporosis. So features that can be worsened by your subclinical hyperthyroidism. So you don't have to remember the whole thing, but just have an idea. If your TSH levels are very low, even subclinically, if you're old, if you have heart disease, symptoms, or osteoporosis, consider treating them. So finally, ladies and gentlemen, to conclude, I've given you a few pearls on the management. I've talked about whom to screen, thinking out of the box when you're screening for hypothyroidism. If your TSH is not normalized, what to do in hypothyroidism. Hypothyroidism, looking for etiology. Special situations, hypothyroidism in the elderly, hyperthyroidism in the elderly, dose management, and also pregnancy and thyroid disease. Hypothyroidism as an important factor in thyroid disease, and postpartum thyroiditis, subclinical hypothyroidism, and subclinical hyperthyroidism. I thank you for your attention. Thank you.
Thank you very much, Dr. Kavinga, for that very informative and very interesting presentation. Actually, we have got few questions now for the question time.
One question is, can we differentiate different categories of thyroiditis depending on thyroglobulin level?
No, actually, thyroglobulin level might not be very helpful in differentiating the type of thyroiditis. That's the question, isn't it? So thyroglobulin is actually, it's released.
Yeah, can we differentiate different categories of thyroiditis depending on thyroglobulin levels?
No, we cannot. So thyroglobulin is basically, it does not affect or help us differentiate the type of thyroiditis, whether it's acute or subclinical or chronic thyroiditis. I think that's what they're asking. But there are certain types of antibody levels. So if it is Graves or hyperacute thyroiditis or subacute thyroiditis, TPO antibody levels can help. You can do TSH receptor antibodies or TRAB antibodies. Those will be helpful, but not definitely thyroglobulin levels.
There's another question coming from, I think, Australia, Binara Jayasinghe. When would you consider thyroxine T3, I think, which is not available here?
Yes. T3 there are very few indications at the moment. One thing is if you have a hypothyroid coma or myxedema coma, where you can give T3 if it is available IV preferably, and very rarely if the patient is intolerant to T4. I have seen only one patient, and that is in UK. Then you can use T3. So apart from that, there are hardly any indications for T3 apart from the intolerance and myxedema coma.
There's another question. Is there a thyroxine dose adjustment? Dose adjustment to be done in post-MI elderly patients?
Post-MI?
Elderly patients.
Yeah, now the thinking is, the thing is that we have to keep the heart rate low for MI patients. Yes,
Yeah.
Is there any place to reduce or any evidence of reducing heart rate by reducing the
really.
thyroxine level? Yeah.
No, there's no evidence. If the patient's TSH level, free TiVo level is normal, there is no need to reduce your dose. If the patient has a tachycardia, that could be due to the underlying cardiac problem, which should be managed by the cardiology team and with cardiac medication. You need not reduce, because reducing the thyroxine level may even increase your mortality and morbidity.
When we started thyroxine for subclinical hypothyroidism, do we have to continue it lifelong?
Good question, actually. Most of the evidence suggests that you might have to, but certain things you can monitor. If it depends on why you started it. Like, was it, for example, if it was just for symptoms, and if the patient is now, the symptoms are improving, the thyroxine levels are quite normal, then you might have a chat with the patient. You're feeling better, your thyroxine levels are getting normal, your antibody levels are pretty low. So this is a patient with low risk where you can actually consider taking the thyroxine off and seeing if this has improved. But if you have very high titers, your TSH was pretty high, the patient was very symptomatic, you might have to consider. It's always playing it by the ear. Most patients with subclinical hypothyroidism, if you actually start on thyroxine, will go on to continue their thyroxine.
Do we have to treat diabetes mellitus patients with subclinical hypothyroidism?
No, there's no indication for purely having diabetes to treat subclinical hypothyroidism. No.
And one more question, Kalinga. Now, from pregnant mother's point of view, you said that we have to disregard the TSH values. Sometimes it's going down, but we don't find any reference ranges, particularly to that population in our country. What is your experience about that? We don't have reference ranges as such in our normal reports.
Correct.
So how can you advise to a normal doctor or other physicians, and to what extent we can look out for?
It's a good point, because it's usually a lab specific value. Individual labs will do first trimester pregnancy patients and then give a reference range. Unfortunately, none of our labs give that. They just copy paste it from one of the European labs. So what we've done as a college is we've put out a guideline, putting out these numbers to say, I've put those numbers up actually. So if you don't have a good reference value, you can use these TSH values for the time being. If somebody's interested in actually doing that, I mean, it's a very easy trial to do, where you actually take patients in their first, second, and third trimester and just do TSHs and see what the normal values in Sri Lanka is. That would be great. If somebody wants to do it, we can always support.
Right. Thank you very much. And I think that brings us, is there another question? Yeah. When is the best time to check TSH? Is it morning or evening?
Well, for any hormone, we prefer to do it in the morning, preferably 8 or 9 a.m. But TSH is a very stable type of a hormone. So it does not fluctuate much during the 24 hours. So you can do it anytime, but preferably any hormone test, better to do it in the morning.
Okay, thank you. Kalinga, now as time is up, and because of the time constraints, we have to stop. And it brings us to a very productive discussion. And I would like to invite you to receive the token of appreciation from Ceylon College of Physicians, and Dr. Priyanka Jayawardena will deliver it to you. Thank you again.
Thank you very much.
Right. So, dear ladies and gentlemen, now we have another teaching capsule session going on in parallel, 2 sessions actually, until 5:30 today. After that, we will be summing up our CCP Annual Conference 2020. And we would like you all to join the teaching capsules from 4:30 to 5:30. And then there's a good news as well. The recorded lectures will be available in our Ceylon College of Physicians official website in the due course. So please feel free to download them and join with that and use it for your educational purposes in the due course. And it will be available in our official CCP website. Thank you very much for you all for joining with us. Thank you again.